A disorder occurs when symptoms have high intensity, frequency, and duration to cause impairment in multiple settings. For kids, I find this to be particularly interesting because kiddos that are having problems just at home or just at school and not both probably do not have a disorder. They probably have a problem with the environment. We don't know what that is. Could be one of the adults there, the teacher, the parent, the other kids. We can't really tell without really doing some investigative work, but it's not a disorder. And a lot of times, I supervise children's services. A lot of times, the grown people in a child's life are real quick to label a kid as having ADHD or ODD, and they need medication. And if we're not seeing it, well, one of the quick questions I get to the meat of it is I say, can any adult get this child to mind? Can anybody impose consequences? And if the response you get is, oh yeah, their grandma, she just looks at them and they calm down. Okay, well guess what? That means it's not the kid. Because illnesses do not differentiate between grandma and mom. So that's important to keep in mind. You'll find that if we say we have 72% of kids in foster care that are diagnosed, I guarantee we have about 80% on medication. We all have symptoms from time to time. Many people have intense symptoms without impairment. Symptoms are not a disorder. I'm told that expectable is not a word. I find it to be actually appropriate right here, so I continue to leave it in here. Symptoms are not a disorder if you can expect them. If somebody dies and you're sad, that is not a disorder. That is normal. If it's culturally appropriate to behave the way you're doing or to do the things you're doing, it's not a disorder. If it's brought on by peer pressure, we see this sometimes because we have we have several universities in town. Young women who diet excessively because of peer pressure, it's not a disorder. It's wrong, but it's not a disorder for them. If the symptoms do not cause impairment, it's not a disorder. These are the common categories we work with. These are the things you'll mostly see. Anxiety disorders can be anything from generalized anxiety, panic disorder, or obsessive compulsive disorder. Mood disorders, the big ones right now are major depressive disorder and bipolar disorder. Bipolar disorder used to be called manic depressive disorder back in the day. Psychosis and psychosis-related disorders, schizophrenia, schizoaffective, schizoid, schizotypal, all those schizo disorders. Developmental, autism, of course, Asperger's is no longer recognized as a disorder, but autism and Asperger's used to be together. And eating disorders like anorexia or bulimia. Any questions? Yes, ma'am.
This is kind of delving into the weeds, but I always have a hard time empathizing. Bipolar, I understand the chemical imbalances that happen. Schizophrenia, I'm very clear, autism clear, and anorexic and bulimia also clear on how their self-image is warped.
Mm-hmm.
Generalized anxiety, is that also of a chemical imbalance nature, or is that something that is just therapy works at it? I always have a hard time understanding what's the best way and why some people have issues getting or dealing with that. You see what I'm saying?
So there's no good long-term medicine for generalized anxiety. Unlike mood disorder, not developmental,
Right.
but mood, eating, and psychotic disorders, we have medications that have been proven to be effective long-term.
Right.
There's no effective long-term medicine for anxiety disorders right now.
Yeah.
Every medication that has good, solid FDA-approved studies behind it is only approved for short-term use. So the clinical answer would be the best response to an anxiety disorder would be short-term medication use to dull the anxiety response enough to engage in the behaviors that give you anxiety, prove to yourself that you can do it, build up some confidence, build up some coping skills, and then wean off the medication. What we see most of the time is people become decade-long users of these medications. So things that would be in that category would be things like Valium, Xanax, Klonopin, your benzos. They're usually blue. Blue usually means controlled substance in the prescription world.
But yeah, I just find it frustrating because sometimes I feel like it's one of the ones I feel like, sometimes I just feel like it's never going to get there. You know what I'm saying? Because you can't just throw a pill at it.
Right. It is
Results.
that family of disorders requires some of the most effort on the person that's rehabbing out of them. Yeah, it's not so simple as taking your antipsychotic medication and trying to get on with your life. It's going to be confronting your fears. If all of us were to make a fear hierarchy and put things that we're afraid of, like all the way up to the thing we're most afraid of, and then I was just gonna sit down with you and say, okay, so what day are we confronting the top of your hierarchy? You'd probably be like, no thanks, I'll just be sick. We're good. Because I know what would be at the top of mine. And yeah, no, it's probably a toss-up between a pit of snakes and sharks. And nope, I'll just be a hermit. Not happening. So I can really, for me, I can see that, like, someone else's fear might be going grocery shopping, but that's their Shark Tank. So I'm going to give them Xanax or Valium to help bring that fear response. Well, I'm not going to. Someone who can legally prescribe it is going to. Because y'all are putting this on YouTube. It's great.
I can edit anything out. Just let me know.
That little thing, I feel like my license might get audited. We can give them medication to dull the fear response so they can crawl into their Shark Tank, but we're still asking them to crawl into a Shark Tank. And I feel like that sometimes is overlooked, that this is a huge undertaking, and we might be more planting a seed.
But sometimes don't the medications cause, have a worse effect on some of them?
Absolutely, absolutely. You ever heard that long string of side effects on the TV?
Yeah, I had a friend of mine, believe it or not, he was a military man, and he was a paranoid schizophrenia.
Yes.
And I used to take him to the VA, and they would say, well, you going to the gold hall, doctor, this time, or the blue hall? And he would go berserk, because he had been used to going to the blue, and they changed to the gold hall.
Yes.
And it was funny walking around with these policemen with one to the other, but he was like,
Yeah.
some days you go over there, fine man, next day you go over there.
Totally different person.
Yeah.
Yeah. Yeah. Can happen quickly. Yeah. Okay, so myths and facts. Y'all tell me if these are true or false, or if it's a myth or a fact. The first one is mental illness is the result of bad parenting.
Possibly.
That is a myth. It was very popular in the 50s and 60s as a theory, particularly myths about the way mothers would parent, whether they were too cold or withheld affection, if that could cause mental illness. It's pretty much been debunked. We're back to the diathesis stress that you're born with certain genes, and those genes are activated by events, which is why siblings are more likely to have mental illness, but they're not guaranteed. Many people fake mental illness to get disability or special treatment in the courts.
That's a fact.
How many are many?
Okay, all right, all
What
right.
percentage?
What percentage? It's actually, it's false based on the fact that it is such a low frequency. It is actually less than the documented number of women who falsely accuse someone of rape. It's 0.0001%. And here's the reason. There's very little incentive to do that. If you are declared not guilty by reason of insanity, instead of going to jail, you go to a mental hospital. You don't just get to go home. Nobody says, oh, well, you did X, Y, and Z, but you didn't mean it. Good luck. You get to go to a mental hospital. There's no release date when you go to a mental hospital. Unlike jail or prison, which gives you a date that you will get out, barring any further problems, When you go to a mental hospital, you are under the graces of the doctors to decide if or when you will ever get out. So for 99% of offenses, you will stay in the mental hospital actually longer than you would have, unless you're a serial killer, which we don't actually have that many of. So any lawyer worth their stuff will tell you that is not a good defense. If you suddenly remembered the day you were arrested that you're bipolar, you should probably drop it because that's not gonna earn you any benefits. Getting disability, does anybody know what the statewide benefit is for disability for SSI is currently? Yes, ma'am.
It's $750. That's who I work for.
Yeah.
So on the other side of that, we see, I mean, I take those claims, and I can take 50 claims in a month. And on an average, when we, because we see the hearing, and I mean, we kind of figured it out because a lot of us keep our own statistics and stuff. And there's a huge percentage that actually, they won't, they don't have anything and they can't get their disability. When they get to the hearing, then they'll pretend or go through like they have some type of mental illness. Because, here recently, we've had a lot of cases coming out of New York and some of the other ones, where they've had doctors and attorneys working with claimants, and they doctored their records to get them on disability. So for us on that other side, maybe take out the court part, we've seen more, probably, they said like in the last 5 years, they've had more cases of people faking mental illness to get on disability than they ever have.
For $750.
For $750, or, because you have to look at the other side, most people look at SSI, but you have the disability side where people have actually worked and paid into Social Security.
Sure,
So
yeah,
that's a higher
no,
benefit.
that's,
Yeah, so we see a higher
But
side of that.
the-
We take the court part out, but we do see we've seen a higher percentage. They said
right.
probably in the last 10 years, it's a higher, especially for children.
So what's the prevalence though? Higher than 1%?
I don't know the exact
Okay.
prevalence. I know we see a higher prevalence in children because
Right.
of the parents than we see in the adults.
Right.
We see it more in the children and the parents getting their kids to act out or trying to get the schools to do whatever and things like that. But the prevalence it's growing. It's not as high as it would, but it's actually growing agency-wide. We've noticed that in about the last 10 years, they said.
So I would just caution you, because growing is not the same thing as many or most.
Yeah.
So the vast majority of people who apply for disability are actually disabled. Because if you're not disabled, living on $750 a month is a pretty horrible concept. Because, I mean, your housing will be $500 to $600 of that in this area. So the last statistics we have say less than 1% of claims are false. Now, an agency like Social Security, you probably get hundreds of claims.
Yeah,
a day.
and I'm looking probably more agency-wide. The
Right.
percentages they've been higher over, like they said, they've been higher over the last 10 years or so.
Yeah.
They used to be a lot lower than they are now.
So there's just not that much incentive to fake a mental illness, especially when you're talking about like a grown person who's already having difficulties and is working a system. Mental illness varies by race or background. That's a fact. Yes, it's found. Mental illnesses are found in every country in the entire world, in every area, as far even places that have indigenous cultures that have very little contact with the developed world. There are words for mental illness, and there are ways of coping with mental illness in that population. Mental illness prevalence varies by gender. It does, actually. Women are 4 times more likely to have a mental illness than men. We have different theories. Nobody can really explain exactly why. One of the theories is that women are socialized to seek help, that perhaps men have the same prevalence, they just don't speak about it and seek help as often about it. And then, of course, the flip side of that is maybe women really do genetically have more of a disposition for mental illness. We really don't know. But yes, we do know that the prevalence varies by gender. Mental illness is very common. Yes and no. This one's actually right both ways. It's common in the sense that the symptoms are very common. It's common in the sense that a lot of fully functional adults deal with mental illness on a daily basis. It's a myth in the sense that it's not the catch-all answer to all of everyone's problems. Anytime something goes wrong, there's an act of violence, there's a school shooting, the first thing people look at is whether or not mental illness played a role. And that's actually not the case. There's very little research-backed link between violence and mental illness. So the fact that we reach for it as the answer to all of society's ills is an overgeneralization. Most people experience symptoms of mental illness over the course of a normal life. Fact. People with mental illness are violent or dangerous. Myth. Total myth. Do symptoms always affect parenting? No. So a lot of people with mental illnesses are great, capable, protective parents. Many people experience symptoms, as we discussed. The vast majority of those with mental illness have fully functional lives, including their ability to safely and appropriately care for their children. A mental illness diagnosis alone does not indicate one way or the other as to whether or not that person is a capable parent. So if you get your case file, and somewhere in it, it says, mom goes to MHMR, that tells you exactly nothing about that person. It tells you that might be a factor, and it tells you it might not. It's the same as picking up a case file and seeing that mom has diabetes. It could be the key to everything, it could mean absolutely nothing. How can they affect parenting? So these are the things that you might want to think about, or the things that you might want to phrase into questions when you're talking to the parents, or when you're talking to the CPS caseworker. If there are any concerns about maintaining employment or income, does their mental illness play a factor in that? Have they lost jobs because of their mental illness? Have they lost their Social Security income because they didn't keep their paperwork updated, they didn't respond to a letter, they didn't do their renews, all those things. If you don't have some organizational skills, even the benefits you get will stop coming. Did your mental illness play a role in that? Difficulty maintaining housing. That's a big one. This country in general has very loose eviction laws. And it's not uncommon, uncommon's the wrong word, it's not unheard of to hear a story like, well, so-and-so went off their meds and was standing outside screaming, and the next day they got an eviction notice. The eviction can't be tied directly to that incident, but if there's anything else, if they're behind in their rent, if they've done any damage to the property, if they've had unauthorized visitors, there's a whole litany of things that are in the fine print of a lease that can warrant an eviction. So it's not unheard of to hear stories like that. Low energy or motivation can lead to neglect. The mom and dad have trouble getting out of bed in the morning, making breakfast, making sure the kids go to school. Racing thoughts or hyperactivity can impair concentration. Poor impulse control or inability to anticipate consequences. Co-occurring substance use. Up to 80% with a mental illness have a co-occurring substance use or history of one. And then suicidal thoughts with intense depression. In this state, if a parent has suicidal thoughts, it's almost immediately a Department of Family Services case, particularly if they're a single parent. Because the idea being, if you're thinking about ending your own life, you can't be responsible for another child, or perhaps you just need a little bit of extra help getting through this area. It doesn't necessarily mean an immediate removal, but it will be a situation where pretty much every mental health worker will report that, and something will come of it.
May I ask, so as a CASA, if someone, either one of the kids or the parent we're interacting with makes any reference to that, we're obligated to report it, is that correct?
You're a mandated reporter, but I would say your first step would be to link them with a mental health person. If they're saying anything related to suicide, I would definitely be the handoff person to somebody in mental health, whether that's the parent or the child, you know. Do what you can to facilitate that within the limits of your role. You know, obviously you're not gonna pack up a 5-year-old without the parent's consent and drive them away, but the first step would be to link with a mental health professional. Ideally, they would do the reporting, and if not, then you would consult with your supervisor, hear about who's in the best role to report that, because that's going to get messy if you're the CASA and now you're reporting someone.
And what age do children start, like, you know, I know teenage suicide's been rising, but at what age do children start voicing suicidal thoughts?
Actually, the fastest growing population of individuals that follow through suicide is the ages of 5 to 12. 5 is the lowest age we track it. Yeah.
So Kate, going forward, will we know how to put them in touch with a mental health
Yeah, Jessie will
professional?
go over that at the end, she'll give
Okay.
you some, and the best thing to remember is Mental Health Mental Retardation Authority that Jessie works for has a crisis hotline.
Yeah,
24
24 hours a
crisis
day.
hotline.
Holidays, weekends, doesn't matter. We're better than the post office, even when it's Memorial Day, we're open. Yeah, that's an easy phone call to make. So, common reactions when somebody has an episode, particularly if they have chronic mental illness, which remember we're looking at less than 4% of the population. Chronic mental illness, they've dealt with it before, they've had it under control before, and then something went wrong. I have lots of families, lots of friends in my office all the time, well-meaning people that love this person, and these are the things that they say. Why didn't you keep up with your medication? That's usually the first thing out of people's mouths. Somebody brought up earlier the side effects. The side effects, okay? Listen closely to one of those commercials, like particularly for your antidepressants. They don't even advertise antipsychotics because there's no market for them. You either need it or you don't. You don't elect to take antipsychotics. But they do advertise antidepressants. And if you listen, there's first weight gain is a big one. Dry mouth, and then all of your gastrointestinal distress, diarrhea, constipation, nausea, vomiting. So if you're gonna gain weight and you're gonna have all that distress, and you're gonna have dry mouth, dizziness, cardiovascular incidents, wouldn't you just rather be depressed? I'm gonna be depressed if I have all of that, you know? So
Don't some of them cause like depression and suicidal thoughts too? Like some
they
of
have
them
been linked to
antidepressants?
suicidal thoughts, yes. Some of the antidepressants, particularly in adolescence, yeah.
A lot of your medications is like that. I was on one, and when I had surgery, and it was called Gabapentin. It has suicidal thoughts and everything. I don't take it. If I got 2 bottles, I don't know.
Yeah.
Yeah,
Yeah,
I did
Gabapentin.
take it, and I lost my wallet, and I still don't know where.
Yeah.
I went to my bedroom, I picked my wallet up, and first at the hospital, I told them to take them tonight. I took a couple of them. I remember getting my wallet, going to my bedroom, and I still hadn't found it. That's been going on for long.
Yeah. And so you understand, at some point you're like, whatever this is supposed to cure, I'm just gonna deal with that. At least I'll have my wallet.
But sometimes these doctors go overboard on prescription. I have a nephew, and a sister, and my husband adopted my brother and his wife who had issues, and they adopted him. They had to go to several doctors to have that medication changed, because sometimes he would have a meltdown.
Yes.
They finally got him pretty 17 years old, and he's going on.
Yeah, it can be a great tool. It can. But it's more art than science. And usually to find that medicine that works, we have to try a few that give you the awful side effects first until we know how you react to it. So I'm always amazed. I go to the ERs a lot to see people that have had an episode. And that's a common question when they're in the ER. It's part of the assessment as far as the medical staff are concerned about, well, did you stop taking your medicine? Why did you stop taking your medicine? And I'm always struck by the disparity, because the next bed over in the ER can be someone who had a heart attack because they stopped taking their beta blockers, and they are never asked if they stop taking their medicine or why they stop taking their medicine. But people with a mental illness are. So that's something to keep in mind. Why didn't you get help with your mental illness? Isn't treatment free at MHMR? Why aren't you going if it's free there? What do you think keeps people from going to their treatment?
The mental illness.
Pride, the mental illness, yeah.
Time, transportation.
Transportation, because we have a great public transportation in the city.
Yeah.
It's fabulous. It'll only take you 2 hours one way to go 3/4 of a mile. It's fabulous.
I still don't know how they know where the bus stop is, like,
Yeah.
There are no
I
bus stops.
I know
You
how
wave
to
your
figure
hand
that out,
and
I
it
just
stops.
see people on the side and I'm like, I guess they're
Yeah.
waiting on the bus.
True story. You wave your
Yeah,
hand and it stops.
yeah.
That's our wonderful system. So never wave at the bus. Doesn't matter who you know on it. Do not wave at the bus. It will stop. Yeah, transportation's awful. Taking time off is awful. The treatments that we talk about, particularly for things like anxiety disorder, that's every week. A lot of people don't have jobs that they can take off every week. A lot of people have trouble with childcare. A lot of people, if you don't have something that grounds your days, like you don't work regularly right now or you don't go to school, Tuesday is the same as Sunday, which is the same as Monday. So trying to keep up with appointments that are regular like that can be very, very difficult. So it's not a matter of it's so easy and I just don't care. It's a matter of there are genuine obstacles to getting treatment. Didn't you think about the effect this would have on your children? Let that one sit with you for a second, because if you have children, or you have children in your life that you care about, someone else's children, your nieces and nephews, you will at one point have this thought when you come into contact with somebody. It's a natural reaction. You will think, there is nothing I wouldn't do for these kids that I care about, and if it were me, I wouldn't have let this happen. And it's not that simple. There are 100 reasons why someone has to make priority decisions. And the reason that that thought can be damaging is it puts you in a position where you're not trying to get at the underlying obstacle anymore. You've instantly put up a mental block about why this was bad and why it's not acceptable. And we just become judging instead of trying to find a solution. And it's not our job to judge, it's our job to find a solution. It may not be a solution that the parents like. It may not even be a solution that's in the best interest of the parents. We have to be in the best interest of the child. But recognizing those reactions is important to really get at what's best for this kid. If I knew that my kids could or would be taken away by CPS, I would manage my medication or treatment or symptoms better. Same statement. If you find yourself thinking it, it's completely normal, it's completely healthy, but try and recognize it and put it aside to keep moving on and working with this person. How could you be so selfish? Again, we don't think about mental illness in terms of someone trying to game a system or trying to get away with something. We think of it in terms of an illness. So when the illness gets the better of them, like if they had a heart attack or they went into a diabetic coma, it's rarely helpful to kind of blame it that way. So, yeah, this is Maslow, this is good. Okay, so there are certain studies out there, they're about 20 years old now, but they're the best ones we have. Late 90s, did some really good qualitative interviews with people about why they went off their medication that was unrelated to side effects. And that was important, because up until that point, all the studies had included side effects, and that just ruined the data. So for people that did not mind the side effects or didn't have any, what were the major reasons why they went off their medication? And they framed it in terms of Maslow's hierarchy of needs. Do they still teach this in school? Am I officially? Okay, fantastic. One day I will be too old and they'll be like, no, there's a new theory. It's not a food pyramid anymore, it's a plate. So it was a pyramid when I was in school. So when we talk about Maslow's hierarchy of needs, the physiological are at the bottom, and you have to meet the needs from the bottom to the top. So food, water, shelter, clothing. Then safety, self-explanatory. If you're not safe in your home, you can't focus on love and belonging. If you don't feel loved and belonged, you can't focus on your self-esteem and love yourself. And then self-actualization is kind of a higher order mindfulness concept of feeling like you have a purpose, feeling like you are making a difference in the world, motivational things. Okay, so when they interviewed people about why they went off their medication, unrelated to side effects, they found that a lot of people were describing their medication in terms of these levels. Well, it's my medication, it helps me feel better, it helps me be a better person, it helps me be more effective and concentrate, but I need that trolley pass to take my kid to school, and that's a basic need. But I need to work to put food on the table and keep the lights on, and that's more important. So people were describing their mental health up here, and all the things that were competing for resources were down here in terms of time and money and energy. And so what we found is the best way to help people conceptualize it is to help them understand that their mental health is actually down here too. It's equal. So we can't just put it by the wayside, particularly for people that live in poverty, because there's never enough resources to ever get up here. So we can't just keep leaving it by the wayside. And we find that to be particularly helpful when working with families as well, extended families, to help them. Okay, well, if they only have enough money for their prescriptions or their utility bill. They used to think I can only do one. Now we need to work on doing them both because they're equally important. So we need to reach out to resources. We need to get on a different insurance plan. What do we need to do? Change the medication. Some are a lot cheaper than others. So speaking of that, treatment. Oh yeah, this is basically what I just said. Cool. Treatment options. We have some major choices. Medication management is the go-to for a lot of folks. Counseling is my personal favorite. Changes in their environment. So if your home life is stressing you out, we might need to change where you live. But no pill is going to take that away. Multimodal just means we do all three of those at the same time. It is by far the most effective. So communication guidelines. I was asked to throw these in.
You've got 15 more minutes.
Beautiful. I didn't notice what time it was when it started, so I was just thinking, I feel like I've been talking for a while. Communication guidelines. So when you're talking to someone with a mental illness, you're going to want to use person first language. So you're going to say a person with schizophrenia versus a schizophrenic. If it ends in IC, it's probably politically incorrect at this point. So it's a person with a disability, a person with depression. They can have symptoms or obstacles, symptoms of psychosis, symptoms of depression, or they can have the obstacles from their disorder, but we don't say suffers from anymore. That's more of the medical model. It's no longer acceptable to use the terms mentally retarded, crazy, or mental patient. Okay. Never assume the presence of symptoms. Always ask. If somebody comes to you, the parent comes to you, the child comes to you and says, I'm bipolar, don't assume what that looks like to them. Ask, how does that affect you? What do your bad days look like? What do your good days look like? What are you hoping to change? There's amazing variety. So these are the acceptable questions. How do your symptoms of X, Y, and Z affect your ability to? And if you need help phrasing those, look at what brought about the removal. Was it lack of housing, lack of employment, not being able to supervise the kids? How would those symptoms affect the ability? And be prepared to hear that it doesn't for a lot of different reasons. It may genuinely not be the reason. There may be some lack of insight there, but it's okay to ask. How have your symptoms been an obstacle in the past? What strategies are you using or are interested in using to help you with X, Y, and Z? What treatment are you interested in seeking or continuing? Or what treatment is CPS requiring you to continue for these symptoms? This one's a big one for me as a CASA. A little bit, yeah, as a clinician as well. But as a CASA, what has your experience with previous treatment been like? Was it positive? Was it negative? What worked for you? What didn't work for you? Because if I'm going into a case and mental illness is a big factor, and the person's telling me it's never worked for them, they've never liked it, they've never stuck with it, I kind of have to weigh that as, okay, well, it's unlikely that all of a sudden you're gonna change. I'm probably gonna wanna see that demonstrated throughout the course of the case. I'm not gonna wanna go into court and it's, permanency and we're all getting ready to make a final decision, and then I'm being told this is the plan. I'm gonna go back and I'm gonna get my treatment and I'm gonna get my counseling. I wanna look at the history there and see what we're working with. Unacceptable questions. Questions of a personal nature. Are you mentally ill because you were abused as a child? Do the medicines make you gain weight? Do you believe the devil is doing this to you? If it sounds like a lot of sensationalism and entertainment, it's probably off limits. Anything that starts with what was it like when? Probably not appropriate. What was it like in the hospital? What did the hallucinations say to you? Not appropriate. That's clinical. That would be helpful for a clinician, but it's not really appropriate when we're determining how functional a person is. The exception to that is information volunteered by the person with the mental illness. Can be reasonably explored if they bring up something as an answer to one of the other questions. How does this affect your ability to keep your housing? Well, whenever the little leprechaun that I see tells me to break a window, I do, and the landlord gets upset. That's a problem. So that would be something to consider. Consent for release of information. Most everybody that you work with that has a license of some sort, an MD, a counselor, the psychological assessments, in order to talk to y'all, they're gonna want a release of information. And they're probably gonna want you to sign their own, because every agency has their own. So if you do want to talk to somebody, a provider of some sort, a doctor, a counselor, whoever, probably the way to start that conversation is to go ahead and call them and say, I'm the CASA for so-and-so. I'd like to ask you for a few questions. How would you like me to sign your release, or how would you like this person to sign the release of information? A lot of them want that person to go and sign it face-to-face, because you never know whose signature it is if they don't do it in front of you. But that's the way to start the conversation. You don't want to get to be like 5 days out from a court report and realize you now have to go get an ROI from somebody. Just be aware, anybody worth their salt's not going to pick up the phone and answer all your questions about somebody's personal business. Employment. Most, if not all, information about mental illness does not need to be disclosed to potential employers. Right now, reasonable accommodations are done, or not, after the hiring process.
Right.
So we can help our families advocate for themselves by not disclosing things that might prejudice somebody against them. MHMR, that's where I work, serves children through adults. The major priority populations for adults are major depressive disorder, bipolar disorder, and schizo-related disorders. Screenings, which are open access, you come in, you don't have to have an appointment, you don't have to call ahead, are Monday, Wednesday, Friday in Brazos County from 8:30 to 2. This current MHMR authority covers 7 counties, and that's different for every county. But for Brazos County, it is Monday, Wednesday, Friday. Helpers in community is something I no longer do. And then we have a 24-hour-a-day crisis line. You can call that. It doesn't have to be a current client. Anybody can call, and that will activate various systems to get somebody assistance. Can be as simple as a screener going out to them. Can also involve maybe one of our CIT, crisis intervention deputies, going out to escort the person to a more structured environment for an interview, like an ER or the office, someplace like that. But we do, the agency does respond to all of those calls. Okay. Questions? Yes.
That one, you're sorry.
Just a second. Yes, ma'am.
I do have a question in regard to like the medications.
Yes, ma'am.
Because we do, try to kind of help people, get assistance. And we do have people that come in those situations where they're not quite eligible for SSI anymore, and they're in the midst of the Medicare, and because they're no longer eligible for the Medicaid, the medications. and they were getting services, and so, you know, where is that in-between, where they can get the assistance, and do you all have information on where they can get that assistance for medications?
So anybody in MHMR services, regardless of insurance, can get their medications. There's patient assistance programs through MHMR that basically has vouchers. My boss is gonna be thrilled I'm putting this on the internet. That anybody that can't afford their medicines, if it's prescribed by our physicians, we find a payer source. And then the individual drug companies, Merck, AstraZeneca, all of them have patient assistance programs, and you just have to prove that you make less than 150% of the poverty level, which,
And that's what I
Should.
thought, because
Yeah.
I'll tell them that they need it, and they'll come in and say, well, I got this cut off, and so-and-so over there is telling me I'm not eligible for medications, and I always tell them I used to work at MHMR a long time ago, so, and I used to tell them, I'm pretty sure you can get them, but for one reason or another, they'll tell us that, and it could be because some of them have been off of their medications for a while, and they're stressing and a little anxious, so, I was just kind of curious
Yeah.
as to where we could send them, so.
absolutely, anybody in services,
Okay.
we get their medications, we find a payer, absolutely. And then if you're outside of services, all of those companies have a patient assistance program on their websites. You just download the application and send in your income information, and they will provide the medication. The only exception to that is anything that might be considered fun. If you can get high off of it, you're gonna pay for it. That is the.
No Xanax for you people.
No patient assistance programs for Xanax or Adderall or anything like that. If you can get high off of it, nobody's giving it to you for free. Like it or love it, that's the way the system works right now. The number for the crisis line. Yeah, don't pick up your pens. I have no idea what it is.
If you dial 822-6467, you'll get a recording that says press 1 for
The crisis hotline. That's what you should do, yes. 979-822-6467. Yes, the very first thing you'll hear any time of day is press 1 for the crisis hotline, at which point you should press 1. And unless you speak Spanish, then press 2, then press 1. But you'll be speaking to someone in Harris County, so the very first thing that you should say is identify which county you're in. Okay? Because again, it covers 7 counties: Burleson, Robertson, Grimes, Brazos, Madison, Leon.
What questions do you guys have for Jesse? Real life CASA volunteer right here, with a PhD, no less.
Do you find that sometimes people get defensive when you're talking about this? And if so, like, how do you work with that? Because there's such a stigma about mental illness. Like, I could see how they just don't want to talk about it, maybe? Or does that not happen?
I tend to take a gentle approach. If I feel like someone's really guarded or having trouble talking about it, I might start with what we agree on. Parents, it's really easy. It's their kids. Good parents, bad parents, parents that have fallen on hard times, they still love their kids. And so I'll usually start there and talk to them about what they want for their child. And then try and weasel my way back into, you know, okay, well, what's keeping you from getting these things that you want from your child? What are some of the difficulties? Sometimes it's just language. Well, they say I have a mental illness. Okay, what makes them say that you have a mental illness? Well, they say I do this. Okay, what makes them say that you do this, that you walk around talking to themselves? Where do they get that from, do you think? Well, sometimes blah, 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 blah. Sometimes matching language goes a long way, I've found. I've also found that if you say it nice and you apologize for it, most people will forgive you for pretty much anything. Yes, sir.
Would you say that the diagnosis usually occurs before the removal process and when CASA gets involved, or are there situations where there's a removal and no previous history, and then throughout the process the diagnosis occurs?
I would say for those people with a chronic illness, that 4% that have the chronic illness, yes, the diagnosis is there. It's been there for years. Whether they've been in treatment for it, sometimes that's not so easy. But for the people that have maybe episodic, I will know this, I do know this, the Department of Family Services loves to put counseling as a service on plans for parents. So at one point or another, most of the parents go through counseling, and through that counseling process, they might get a diagnosis, or they might get recommended to follow up with MHMR for medication management or something like that. So most of our parents that we work with do have contact with a mental health professional, which means they're more likely to be diagnosed. But the chronic illnesses are usually, the diagnosis is there before there's any sort of CPS involvement.
Like, what would happen sometimes you hear a lot of parents say, well, ain't nothing wrong with my child, they ain't gonna give him his medication. You know, we hear that a lot, you know,
Mhm.
just people talking about that. I worked at the school system and I loved the fall, and there was a lot of parents wasn't giving their kids the medication, wasn't trying, they used it like except their other stuff, but there was a big interruption in the classes.
Mm-hmm.
And then you talk to the parents, oh, I stopped giving my child and he don't medicine.
Mm-hmm.
What kind of problem with that? If you have a diagnosis for it,
Yeah,
you know.
yeah, I mean, if there's a genuine need for a medicine, it would be a lot like withholding insulin from a kid that's diabetic. So that would be, one of you is wrong. That's what I tell parents. One of you is wrong. The doctor is saying the kid needs the medicine, you're saying he doesn't. We gotta figure this out. We can't just both agree to disagree and walk away with a diagnosis and an unmedicated child. We've gotta figure out what's really going on.
I heard this lady make a statement several years ago. She said, my boy didn't need that medicine, I just beat it out of him.
Yeah, that would be,
I was at the store, I was just listening and waiting in line, and these two women talk.
yeah, that's a different parenting mindset that was a little more common maybe 40 or 50 years ago, but not the best choice of correction these days.
But say for instance, if you go to one of these families that's having issues and the parent tell you that, well, my doctor says this, and I say that, then what other resource would I have to go to?
You can refer them to Children's Services at MHMR. You'll probably want to get that release of information signed so that you can talk to the doctor's office. Because a lot of times medical jargon is hard to understand and there's a lot going on. And so sometimes people may not have a really clear understanding of what it is. So it's good to get all those facts lined up before we really take some action. Yes, sir.
Question on the consent form
Yes.
piece. So we're dealing with an organization and we're trying to get information from, they want a consent form signed by the person
Mm-hmm.
in person.
It depends.
How does that work though if that person has no way to get to the organization?
That's
Well,
the trick.
Theoretically, because it's not always the case, weird stuff happens. If it's a provider, then that person's in services, and those services are likely to be in person. So the next time they go to X appointment,
Okay.
they sign the consent. Theoretically, it would also be on them. So you're talking to parent Allie Smith, and you say, Allie, I need your therapist to sign a consent. The next time you go to your therapist, tell them you want to sign a consent. And they do. Like, they go and they say, hey, therapist, I need to sign a consent for my CASA. And it's done, and you don't have to, like, hunt them down. That's really ideal situation that never happens. Probably.
Sometimes CPS has the consent.
Sometimes CPS already has the consents, yeah.
Or you can get them in that family group conference.
That we fall under, like?
Yeah, well,
okay.
no, if you were at a family group conference, which is the first big meeting with CPS, you could say to Mom, I'm really gonna wanna talk to, I don't know, your counselor, could you sign this consent form? They usually, it's a little under duress because they're there and they're in the CPS office and most of them aren't gonna say no, but it's a good way to get it done.
Right.
Yeah, my office would take consent signed without like if you were to bring it in and say this is so-and-so. Some providers are gonna say it's in person. Just just feel them out and say, I need this information, what's the best way to get that consent for you? See if they have their own, that's the biggest time waster from my work, is I get a consent, I track the parent down, and then I go bring it to someone, and they're like, oh, but it's got the wrong heading, we have ours that has our letterhead, and I'm like, well, give me some scissors and some tape, and I can fix it for you, so.
Yeah. Any other questions for Jesse? Yes, ma'am.
With stuff like that, so if we have like a general release of information, do we let them make a copy? Do we keep the original? Do we turn in the original? Like what?
I would keep a copy for yourself. I would let whoever it belongs to have the original. I think that's the best bet. All right. Thank you, Jesse, for being here. I'm not real fast. She said I'm not real.
Yeah, you lost a fight with somebody.
We're so glad you would be here, especially after a long Monday at work, and so, thank you. Oh, I knew you would like it.
I do, I love your Pinterest stuff.
I know, Pinterest is a great thing. Right. Thank you. All right, before we have our next speaker, a couple of things. I just put up here an updated schedule for us. It's just got a couple of new topics, no times or anything have changed, but that'll let you know. One of the handouts you got was day one feedback. I forgot to hand it out on Saturday. And so if you would just take a few minutes and do that for me. We really do change this training based on what you tell us. We've changed it pretty significantly over the last year, just based on our feedback. Also, the extra bathrooms, they're upstairs. Now we have 2 instead of 1. So if you go upstairs, the second door on the left, you can go through there. There's a bathroom in there, or go all the way to the back to, what is it, 115A?
Everywhere.
All right,
Swap the
Lori,
signs.
Lori put up the sign, so that is our extra bathroom. Let's see, and again, if you miss Saturday, just plan on being here for 10 or 15 minutes after we get done tonight. All right, so let's take, we've got 10 minutes, let's take a break, and then if you want to get your picture taken, which I highly recommend because Myra's here to sit, and she takes great pictures, just come on into the snack room. It's a conference room, but we're calling it the snack room.
If you don't take it today, I'll be here tomorrow to take
Lindsay, did she tell you to flex out some of your time?